In this part, we're going to look at mean arterial pressure and its regulation. So it's really important to regulate the blood pressure because this is going to determine the blood flow to the organs. So remember our flow rule, cardiac output or blood flow is equal to MAP divided by the total peripheral resistance. So if you increase or decrease the blood pressure, that will affect the cardiac output, the blood flow to the organ. And then we're just going to rearrange our flow rule down here. We just solved for MAP. And then remember that cardiac output is heart rate times stroke volume. So we can say that MAP is equal to heart rate times stroke volume times total peripheral resistance. There's 4 factors that affect blood pressure. So there's peripheral resistance, cardiac output, blood volume, and vessel elasticity. So let's take a look at peripheral resistance first. So if you change the total peripheral resistance, that will change the mean arterial pressure. So in changing the resistance, the most important factor is the blood vessel diameter, because remember the body can very quickly vasodilate and vasoconstrict. So let's take a look at a picture of that. In this picture on the right, you can see that they've vasoconstricted the blood vessel. And when that happens, the blood will back up behind the constriction, and that'll increase the blood pressure. So if you increase the resistance by vasoconstricting, that will increase the blood pressure. And if you decrease the resistance by vasodilating, that will decrease the blood pressure. Cardiac output also affects blood pressure. So if you increase cardiac output or increase blood flow, that'll increase the mean arterial pressure. And if you decrease cardiac output or decrease blood flow, that'll decrease the mean arterial pressure. Remember that cardiac output is calculated by multiplying heart rate times stroke volume. So if you increase the heart rate by increasing sympathetic stimulation to the SA node, then that increased heart rate will increase the cardiac output, and then the increased cardiac output will increase the mean arterial pressure. If you decrease the heart rate by increasing parasympathetic stimulation of the SA node, the decreased heart rate will decrease the cardiac output, and then the decreased cardiac output will decrease the mean arterial pressure. And then stroke volume can also affect cardiac output. So if you increase the stroke volume by either increasing venous return to the heart, so that would increase the preload or the end diastolic volume. If you increase contractility of the ventricle, make it contract harder by increasing sympathetic stimulation, or if you decrease the afterload, so the pressure in the aorta and the pulmonary artery. So all of those will increase the stroke volume, and if you increase the stroke volume, that'll increase the cardiac output, and then increasing the cardiac output will increase the mean arterial pressure. And if you decrease the stroke volume, that would decrease the cardiac output, which would then decrease the mean arterial pressure. Here's a picture just showing the change in cardiac output. The bottom picture, we've increased the cardiac output or blood flow coming into the aorta. We have not changed the resistance, so we haven't vasodilated or vasoconstricted. But by increasing the blood flow or cardiac output into the aorta, we've got a lot more blood coming into the aorta, and then not quite as much can fit through anymore because you've got so much more blood. So the blood will back up and increase the pressure in the aorta. So you can see that by increasing the cardiac output, the blood flow, that will increase the mean arterial pressure. So this is just the same as if you imagine if you have a garden hose, and if you increase the flow of water through the hose, like you turn the faucet up a lot, that'll increase the pressure of the water coming out the hose. And if you turn the faucet down, and so now there's not as much water flowing through the hose, that'll decrease the water pressure coming out of the end of the hose. And then another factor that affects the blood pressure is blood volume. So if you decrease the amount of blood, that will decrease the blood pressure because now there's not as much blood putting as much pressure on the walls of the blood vessels. So decreasing blood volume maybe is caused by dehydration, or maybe there's been some blood loss. If you increase the blood volume, maybe the kidneys are failing and you're not able to get rid of as much water as you should, that'll increase the blood volume, put more pressure on the blood vessel walls, and that'll increase the mean arterial pressure. And then the last thing that affects the blood pressure is vessel elasticity. So this is a concern with atherosclerosis, or hardening of the arteries. So remember, this is where you get the fatty plaques that build up in the arterial walls. So you can actually see that here on a cross section. And when those fatty plaques build up, they will decrease the diameter of the blood vessel. So if you decrease the diameter, that's like vasoconstricting. That'll increase the resistance, and that'll increase the blood pressure. And then also, where the fatty plaques get laid down, the blood vessels start to calcify. So they become really hard, and there's no stretch or give to them at all. And so when the arteries harden, that also increases the resistance and increases the blood pressure too. It's really important for the body to regulate the blood pressure. And that's because the blood pressure affects the cardiac output, or blood flow to the organs. So if the person has hypotension, so the MAP is less than normal, this is bad because the low blood pressure means that there's going to be less blood flow to the organs, less cardiac output, and then the organs will start to die. So hypotension is very serious and it can kill you very quickly. Hypertension is when MAP is above normal. So this is bad because it makes it more work for the heart, and it's also hard on the blood vessels. The heart has to work harder to pump the blood because the afterload, the high blood pressure in the aorta and the pulmonary artery, that's going to create a situation where the heart has to work harder to get the blood around. And then also the higher pressure in the blood vessels damages them. So it leads to more atherosclerosis, the fatty plaques building up in the blood vessels, and also you can weaken the blood vessel walls and get an aneurysm, and that might burst. There's 3 ways to control the blood pressure and blood flow to the organs. Intrinsic regulation, these are coming from local factors around the blood vessels, and this is going to regulate the blood flow to the organs. So we'll look at autoregulation, where the tissues regulate their own blood supply. The next lecture, we're going to look at extrinsic regulation, and this is where outside factors regulate the blood pressure. So that will be the nervous system and endocrine system. So let's take a look at autoregulation first and how it controls blood flow to the organs. So the smooth muscle around the arterioles and those precapillary sphincters, they're going to contract and relax based on local factors. So they'll control the blood flow to the organ that way. There's 4 different responses that we're going to take a look at: active hyperemia, reactive hyperemia, the myogenic response, and some vasoactive chemicals. So these are all going to be acting locally and will affect the arterial smooth muscle and the precapillary sphincters, and that'll control the blood flow to the organ through the capillary beds. So let's take a look at active hyperemia first. And if you look at the name, hyperemia, hyper meaning more than, excessive, and emia is talking about the blood. So active hyperemia just means that we're going to increase the blood flow to organs that are more active. And if they're not as active, we decrease the blood flow. So how the body knows whether the tissue is active or not is that it'll look at the oxygen and carbon dioxide levels. So if the tissue is more active, the oxygen levels become low, carbon dioxide rises, and that will stimulate the smooth muscle around the arterioles and the precapillary sphincters to vasodilate. And that'll increase the blood flow to that organ, and so that's called active hyperemia. If the organ is not as busy, then the oxygen levels remain high, CO2 levels low, and that'll cause the smooth muscle to vasoconstrict, and that'll decrease the blood flow to the organ. So we're going to vasodilate and vasoconstrict to match blood flow to the tissue's metabolic needs. So that's active hyperemia. And here's just a picture just showing you active hyperemia, and showing you in blue is the oxygen getting low, and the green is carbon dioxide, which is building up. So the smooth muscle will sense that and will vasodilate, and that will bring in more oxygen and get rid of the CO2, and that'll satisfy the organ's increased demand for more blood flow because it's more active. So that's active hyperemia. Active hyperemia obviously occurs during exercise. So let's just take a look at some graphs. So here's the person at rest, and you can see how the cardiac output has been divided among the different organs. Remember, that's that parallel blood flow. So whichever organs are more active get more blood, and if they're less active, they get less blood. And then notice when you start exercising, we're going to vasodilate to the skeletal muscle because they're really active, working hard. And so we're going to divert more blood to them. And then the other organs are not quite as busy, so we're going to vasoconstrict to them. We also have reactive hyperemia, some more local factors affecting blood flow to the organ. So this is different because the tissue is going to react because you've created a blockage of blood flow to the tissue called ischemia. And if you block the blood coming into the tissue, that's going to decrease the oxygen and increase the carbon dioxide. So that'll cause the smooth muscle to vasodilate, but you're not going to be able to get any blood in there until the blockage is released. And then once that blockage is released, the blood will flow in there and bring in more oxygen and get rid of the CO2. So it's just like if you were to push down on your skin and create a temporary blockage in blood flow. When you release that, the blood vessels have vasodilated, and then the blood will rush in there to replenish the oxygen and get rid of the carbon dioxide. So that's reactive hyperemia. It's really important to note that reactive hyperemia is due to decreased blood flow to the tissue, whereas active hyperemia is due to increased activity of the tissue. So keep those two straight. Okay, and then another local factor that affects blood flow to the organ is called the myogenic response. So if you look at the word myogenic, myo is talking about muscle and gen means to produce. So our blood pressure does fluctuate during the day and depending on what we're doing, but most of the time we want to keep the blood flow to the organs constant. So if you increase the mean arterial pressure, that'll increase the blood flow and pressure in those arterioles, and the arterial smooth muscle will stretch. And then it reacts with this myogenic response to the stretch by constricting. And that'll decrease the blood flow to that organ and make sure the pressure doesn't get too high in that capillary bed because we don't want to rupture the capillaries. And then the opposite happens if the blood pressure gets too low, then there's not as much blood flowing into those arterioles, so they're not stretched as much. So they do the myogenic response and react by vasodilating. And that'll increase blood flow to the capillary bed and make sure that we're getting enough blood to the organ. So that's the myogenic response. And then the last thing that can affect blood flow to the organs by local factors, there are some vasoactive chemicals. So these are going to be released, most of these from the blood vessel walls. So nitric oxide is a gas, and we'll talk about that one again later, but that can cause vasodilation. We're going to talk about histamine later too. That's released during inflammation and allergic reactions by some of our white blood cells, and that will vasodilate, and so does prostacyclin. That's also another vasodilator. And then there are some vasoconstrictors. I just want you to be familiar with these names. You've at least heard them because we're going to be talking about them again.